Hi, everyone. My name is Brooke Rossi. I am a reproductive endocrinology and infertility specialist at Ohio Reproductive Medicine in Columbus, Ohio. And this is, go ahead, Lindsey.
Hi, I'm Lindsey. I'm one of the senior embryologists here with Ohio Reproductive Medicine. Been here about 6 years, so some of you might recognize me from maybe an embryo transfer or retrieval, but lovely to talk to you guys today. We're excited to go over some embryo grading with you. That's what we do all day.
Yeah, so today what we're going to do is talk a little bit about embryo grading. So we get a lot of questions from patients about embryo grading. And in general, embryo grading is a very important part of the IVF process where the laboratory staff or the embryologists look at the embryos and look at them underneath a microscope to try to assess if they're viable, if they're growing, are they growing at a normal rate? And there are some benchmarks that we expect embryos to reach over the course of several days that they're growing in the laboratory. And then we use their development and we use sort of when they reach these benchmarks to help us understand if that's an embryo that is going to help patients have a baby. So what we're going to do today is talk a little bit about embryo grading. Embryo grading is how the embryo looks and different qualities about the embryo.
So at our clinic here, we use the Gardner's grading system. So it's a scale that it's pretty widely used throughout many clinics in the US. So that's what we use here. Basically what the grading refers to is, like Dr. Rossi mentioned, it's the physical appearance of the embryo. So we're looking at that embryo at one point in time. So that doesn't necessarily tell us everything we need to know, but it gives us a pretty general understanding. So we're grading based off of appearance.
And it's important to note too that when what we're talking about is just specific to the Gardner criteria. Mm-hmm. So some clinics have different criteria, and it's fine. Everyone can do their own thing. You just have to. It's like speaking a different language. So you just have to make sure with your lab that you understand what information they're giving you about the embryo when they're talking about these different ways to grade embryos. So in the process of thinking about embryo grading, it probably is worthwhile just sort of reminding everybody about general embryo development. So the day that we do the egg retrieval, or the day that the eggs are thawed, whatever it may be, the eggs are then put with the sperm, and that is considered day 0. So the eggs at that time have something called a zona pellucida around them, which is sort of the protective shell around the egg. So the sperm go through the zona pellucida, and then the embryo grows within the zona pellucida. So then later on in development, when the embryo is about to implant on the wall of the uterus, the embryo actually hatches out of the zona pellucida so that it can implant on the wall of the uterus. So the fertilization, again, happens on day 0. On day 1 is the day that many patients are told how many embryos they have, so they can see signs of fertilization. Rarely we may see that another embryo that we didn't think has an egg that hadn't fertilized actually does and will continue to grow. But in general, patients are told the day after the egg retrieval how many embryos they have. And around day 3 is considered a cleavage stage development. And occasionally we will do a day 3 embryo transfer or a cleavage embryo transfer. At that point, we expect the embryos to be around 6 to 10 cells. And so there's kind of actually even a different grading system for cleavage embryos. Like they're usually, we say like how many cells they are, and then sort of how clear the embryos are, how the cells are in the embryo. Day 4 is often considered the morula stage. And you can't really do much grading of a morula because all the cells are very compacted. It's actually called a morula because it looks like a mulberry. Like a little berry, because all the cells are together. And then day 5 is when we would expect to start to see blastocyst development. A lot of clinics right now are doing blastocyst transfers. And so a lot of the assessment is being done on day 5, 6, or 7. Mm-hmm. And that may vary from clinic to clinic. Sometimes it varies based on the specific patient situation as well.
Yes. So like Dr. Rossi said, there are cases where we do assess on day 2 and 3, and that would be typically if we do a day 3 fresh transfer for the cycle. But for the majority, we would do day 5, 6, and 7 for grading assessments.
And I think it's also important to understand that with embryo grading, this is literally like one 5 minutes of the day that the embryologists are looking at the embryo. So, the embryo is constantly growing, but they just happen to look at it at whatever, 8:30 in the morning. Yeah. So it may change a lot after that. So we definitely appreciate that embryos change very quickly, and the grade that they get one day may be very different than the grade that the embryo gets the next day. So. Okay, so let's say, Lindsey, it's day 5, and you're going to grade some embryos. Okay. So those embryos may have just literally been sitting in the incubator for several days, not assessed. So you're going to take the embryo out, and what kind of things are you looking for when you're trying to grade an embryo?
So we are looking for, basically for day 5, 6, and 7, we're looking at the stage at which the embryo has progressed. So that'll tell us a little bit more about the rate at which it's growing. We're looking at the quality of those cells on the embryo. So there's 2 sets that we'll go into a little more detail. But essentially, we're looking at those components combined to give us the best opportunities to select an embryo for transfer.
So I don't know. This is a funny way that I think about embryos, and maybe this will help, maybe it won't. But I kind of think that the embryos have to cross a finish line, right? Like, as you know, not everybody runs at the same pace. Not all the embryos grow at the same pace. So for example, in a lot of clinics, an embryo needs to be a blastocyst, but it needs to be a developed blastocyst, not an early blastocyst. So sometimes that embryo meets that benchmark or that goal on day 5. Oftentimes it takes until day 6. Sometimes it even takes until day 7. So once the embryo reaches that point, sometimes it will either be transferred, biopsied, or frozen. So the first thing you're looking at is you're trying to see what is the stage of embryo development. Yes. Did it even make it to the stage of blastocyst? And then if it's a blastocyst, which we would expect around day 5, 6, or 7, is it early? Is it developed? Is it expanded? So you're looking at sort of like, and that's what the number is. So if you talk to your clinic and they say, oh, it's a 3BB, that first number is the stage of blastocyst development.
Yes.
And it goes from, what does it go from?
So it starts at stage 1, which would be the earliest blastocyst it can form. It's starting to move from the morula stage into that blastocyst stage. There's something we call cavitation, which is when the embryo is beginning to create, it's a fluid-filled cavity. So that also is a representation of how far an embryo has developed. So if it starts to show that cavity, we know that it's reached that early blastocyst stage, and then so forth from stage 1. 2 is a little bit more progressed as an early blastocyst. 3 is what we just call a traditional blastocyst. 4 is an expanded blastocyst, which is a little bit further along than a 3. The zona pellucida surrounds that embryo, so that starts to thin at stage 4. So that's another differentiator. Stage 5 is when the embryo starts to hatch out of that zona pellucida. So you'll see some cells kind of popping out. It's a good sign. So we know that the embryo is getting ready to try to implant. And then stage 6 is when that embryo is fully come out of that zona. So that is really when the embryos, we call it kind of stickiness. So there's cells that will stick to your uterine lining. And so 6 is the most fully developed an embryo at the blast can be. So.
Different labs may have different criteria for at what point they will consider an embryo developed enough for either biopsy or freezing. So you're looking at the embryo underneath the microscope, you're assessing the stage of development, and then as patients may have heard in our lab or labs that use the Gardner criteria, they'll say it's a 4BA. So tell us a little bit about what those letters mean.
Yeah, so that 4, again, like we just talked about, that's the stage of development. So the first letter that you see is referring to the embryo's, what we call the inner cell mass, or ICM. So that's just a collection of cells that start to compact together within that fluid-filled cavity of the embryo. And that's what will ultimately become the developing fetus. So we'll assess that on a scale of A, B, and C.
I'm going to show you this picture. Sorry, guys. I'm a better doctor than I am artist, but the inner cell mass, so the blastocyst kind of develops into 2 different areas. So what Lindsey's saying is that this area here is the inner cell mass, and then there are cells up here that become the trophectoderm. And she's right. The inner cell mass is what ultimately becomes the fetus.
Yes. So very important. We like to assess those very critically and make sure that we're looking at the ICM as a whole. And so that scale is A through C, which I can go into a little more in depth. The trophectoderm cells, as Dr. Rossi mentioned, those are the cells that are surrounding the entire embryo. They kind of make up the outer lining of the embryo, aside from that zona pellucida that they're in that's kind of protecting them. So that trophectoderm will ultimately become what would be the developing placenta. So it's also very important for attachment. So that those cells are very sticky and they like to attach, which is a good thing. So we want them to attach and ultimately implant. So very important, both of those criteria.
So the A and the B has to do with how the cells, either in the trophectoderm and or the inner cell mass, look. And again, different labs have different criteria of which, some labs will not use embryos that are graded C, some will, but that's the explanation for what that means.
So I wanted to talk a little bit about that BA grading that you see for the ICM and the trophectoderm. So after we grade the stage of development, that ICM is the next letter. So we grade that on a scale of A to C, A being the best. And really what that means is the ICM, which is the cluster of cells that form, those cells, we want them to be really compact, and we want to have a good quality and good number of those cells to form a really healthy ICM. So really when we're grading those ICMs, those are, we kind of want them to look like a little, I compare it to a meatball. Maybe that's the Italian in me, but I compare it to a meatball where you want it to be very compact, you want it to be a good sized meatball, and you want it to be nice and tight and all in one piece. So that's what we like to see for a nice healthy A ICM. The B grading might just be a little bit looser. Maybe it didn't get packed down quite as much as we need it to, but there's still plenty of cells to be a healthy ICM and to create a beautiful fetus in the future. So that is still a very good grade. We still like to see A and B. Those are excellent gradings. Once you get to that C range, typically what we see is there's maybe not a sufficient number of cells present, or those cells that are there aren't necessarily good quality cells, and they might be grainy, and they might be what we call, it's called fragmentation, which is present in a lot of embryos. And really what that is it's just the embryo kind of spitting out some of the junk from during the development. It's trying to correct itself. So that's a lot of times just metabolic waste that the embryo is trying to get rid of. But when you do see a lot of presence of that, it could just tell us that the embryo has to do a lot of correcting, which would necessarily mean we don't want to maybe select that embryo first, or we want to give it more time to actually make those corrections. So the C grading typically will have some fragmentation present, less cells, not very compact like we want to see. So that's really what that means for the ICM. To touch base on the trophectoderm development, so those cells, those are making up the exterior of the embryo. So we call those are trophoblast cells, and we grade those on a scale of A through C, just like the ICM. So what we want to see with those trophoblast cells, in an A grading, is we want to see a lot of cells, like a sufficient number that are evenly distributed around that embryo. So they're kind of woven, a lot of times they're compared to a cobblestone-like appearance, where those cells are just really neatly organized and tightly packed, and there's plenty of those cells. So that's what an A grading usually is. There's no fragmentation like we talked about earlier present. Cells are evenly distributed, and there's a good number of those cells. So for that B grading, it's pretty similar. There's going to still be a sufficient number of those trophoblast cells present, pretty evenly distributed again. The only difference really being is that there might be some cells that are maybe irregular or a little too large. So that's what kind of bumps it down to that B grading. Still an incredible grading to have. So that C grading is kind of where things get a little bit trickier, because you still might have some of those trophoblast cells present, but not to the extent that is needed for those to continue to develop. So sometimes that just means the cell needs more time to grow and generate more of those trophoblast cells. They could be sparse in their development, and they might not have the quality that we need them to have. But their fragmentation is present usually in those Cs, and sometimes there's really little to no trophoblast cells present at all. So that's what the C grading is. It might just mean the embryo needs more time. If we assess that on day 5 as a C, and we look at it again on day 6 and it's an A, great. But sometimes that does tell us that the embryo might just not have what it needs to generate more of those cells for implantation and for the placental development.
I hear actually a lot about fragmentation in cleavage embryos, but I know it exists in blastocyst embryos as well. Can you tell us a little bit about that?
Yeah, so for cleavage embryos, we actually do see that's what our grading criteria is really a lot of times based off of for the cleavage stage. We do the embryo number, and then we assess for the embryo quality, which is
like how many cells the embryo has.
Yeah, how many cells the embryo has. So then that quality is the A through D grading, and that's a lot of times based off of the fragmentation that's present. And again, so I kind of touched base on this earlier, but fragmentation is really just the embryo trying to correct itself, and it's kind of spitting out that metabolic waste. So the more you see of that is typically a sign that, okay, this embryo needs to do a lot of correcting to get where it needs to be. So it might just not be quite ready at that moment in time when we grade it. But the A grading is less than 5% fragmentation, and the cells are nice size or evenly sized and symmetric. For a B grading, it's 6 to 25% fragmentation. So it's a little bit more, still not, too much fragmentation going on. That's pretty typical. We see a lot of Bs and sometimes a lot of Cs too as well, which is up to 50% fragmentation present. And then once you get over that 50% threshold is when you start to bump down to the D grading. And that we don't typically see a lot of Ds, fortunately, but they do happen. And again, it could just be that embryo just needs a little bit more time to get to where it needs to be. So
in the freezing process, as the embryo is frozen and thawed, when do you give it the grade? And does that grade change at all when it gets thawed?
So we assess the embryos during the IVF cycle on day 5, 6, and 7. Those are the days that embryo could potentially make it to that blast stage with the quality and criteria for the freezing. So at that time, if it's assessed and it does meet that criteria and it's frozen, that grade is what is given at the time of freeze. And that is typically after we thaw it, that embryo is kind of frozen in that stage. So there really isn't much change after that from the time the embryo is frozen to the thawing. By the time it's transferred, it hasn't really done a whole lot in that small amount of time. It doesn't take very long to thaw the embryos. So we transfer them pretty soon after that. But it will potentially change in utero. So just to keep that in mind. But that freeze grading is pretty much what you're going to see at the time of frozen embryo transfers.
And this whole idea about the embryo having 2 different areas of cells is very important. So for patients who choose to use any sort of pre-implantation genetic testing, it's important to understand that what we're doing is we're biopsying the cells from the trophectoderm. So at this stage of development, all of the cells should have the same genetic information. So you should be able to biopsy the cells that will become the placenta, but you should still get the same genetic information about the cells that will become the fetus. But we don't biopsy the cells that will become the fetus because obviously those are needed. So it's just important to understand that with PGT, or the genetic testing, that we're doing what we call a trophectoderm biopsy. So if you hear that word, what that means is the cells are being taken from the part of the embryo that's the trophectoderm.
Yeah, and I think just along that note, for our assessments for embryo biopsy, it's a little bit different just because we are taking those cells off of the trophectoderm. So we want to make sure we have sufficient cell quantities for that process. We don't want to take too many cells. So sometimes embryos on day 5 might not be quite ready for that process to undergo the embryo biopsy. So we will have to potentially grow those out a little bit longer just to get enough cells to, keep some left for the embryo to continue to grow.
Sometimes we have patients who will do an IVF cycle and they're told they have like poor embryo quality. Sometimes what that means is that maybe their embryos didn't develop well, maybe they didn't have any blastocysts. And, sometimes that is kind of within the patient, like sometimes there's nothing we can do with that, but there's often many things we can do with that. Sometimes by changing the medication protocol for IVF, sometimes changing how we select the sperm in the laboratory, sometimes additional testing that patients can undergo can help us try to improve embryo quality as well. So we always want to be thoughtful about, changing protocols to try to make embryos better from cycle to cycle. The other thing to understand, I think, is really, really important is how the embryo looks and the grading that it gets does not predict whether it's genetically normal or not.
Yes. Yep.
And so this is, I think, can be hard sometimes for patients to appreciate. Like they may have a beautiful looking embryo that's like a 5AA, and we may get genetic results on that embryo and it might not have the right number of chromosomes, or we may put that embryo into somebody and they may have a miscarriage because it's genetically abnormal or not get pregnant. So just to understand that the genetic testing, or I would say the genetics of the embryo, is not predicted by the way it looks.
Yes.
Which is also kind of a good thing too, because sometimes patients, feel like, oh, all I have is this 3BB embryo, but sometimes that's the one that gives them the baby.
Yeah,
because it's normal.
You see that all the time. So yeah, do not be discouraged if you do not have that perfect AA grading. That doesn't necessarily tell us all the information, like Dr. Rossi said. We see plenty of pregnancies from BBs, so do not be discouraged at all. It's really good grading. I mean, really
the grading just kind of tells us about implantation potential. It tells us like how likely is that embryo, able to implant. Also kind of how well is it able to be thawed and, survive freezing and thawing. But really it tells us more about implantation potential than really anything else.
Yes. Yep.
One of the other things that patients sometimes ask, the pace at which the embryo grows or gets frozen or its ranking has nothing to do with birth defects, any health outcomes with the baby. So just because an embryo is a B instead of an A doesn't mean it's going to be more likely to have any issues when it becomes a baby. So the growth of the embryo really has to do only with implantation, nothing to do with obstetric outcomes or baby outcomes down the road. Even with the best embryo, Lindsey has ever seen, the chance of having a baby from that embryo may only be 50 or 60%, even if it's genetically normal, even if it looks perfect in the lab. And it's just because there can be other things going on either with the embryo or with the patient or with the uterus that don't allow that embryo to grow and become a baby. And so it's always, we're always paying attention to that and understanding if there's anything else that could be going on. And that doesn't tell us anything about the rest of the embryos often, just because what we think is the best embryo doesn't give you a baby. That doesn't mean that the next best embryo won't, or it doesn't even mean that the embryo we think is the least best looking embryo might be the one that you get the baby from. So just understand that, there's always a good chance with any of the embryos that we think are good enough to biopsy or freeze. And that it's really, in some ways, embryo grading is very much just like a beauty contest. Mm-hmm. Like we're just seeing which ones look the best, but sometimes the ones that might have, a lower grade are still the ones that will give babies.
Yeah, I think that's a great point Dr. Rossi makes. Don't give up hope if you have a BB embryo. It's okay. It's a nice embryo. And again, we're trying to make that criteria strict so we know that these embryos that we are going to potentially thaw and transfer back into you are going to give you the best chances for a positive outcome. So that's a lot of what goes into our grading process, is mostly for the best selection and to just give you, the best opportunity for success.
There's a lot of attrition along the way in an IVF cycle. So it's very likely that you may only have 25 to 30% of embryos from eggs that you start with. That's normal rate. So there's a lot of ups and downs, I think, with an IVF cycle. And so I really think it's important for patients to really just kind of hang on. Like if you get, if you find out the day after your retrieval that you only have X many embryos, like just hang on. Those embryos might grow really well in the lab, and you might actually have more embryos than you think you're going to have at the end. And also understand that, sometimes, again, it's hard to be told you don't have many embryos frozen, but the ones that you have frozen then are very good quality. So any embryo that gets frozen or biopsy, you can rest assured that that is one that will give you a good chance of getting pregnant. At our clinic, and I'm sure this is true of many clinics, we could freeze more embryos that are poorer quality, but then that's not going to help patients have babies with them in the long run. So we are very selective about the embryos so that we know when we're actually using them that they will give our patients a good chance of getting pregnant. So, well, thank you everybody for spending time with myself and Lindsey, our senior embryologist today, to discuss embryo grading. This is a very important and somewhat complicated part of the IVF process, so please feel free to talk with your providers if you have any questions about embryo grading. And we wish you the best of luck.
Yeah, thank you guys. It's a privilege to be able to help you guys in this journey. I know it can be a lot at times, but we're happy to be a part of that. And hopefully you got something from this talk and you're able to learn a few things about embryo grading and how that looks. And we're rooting for you guys always, and we wish you the best. Take care.
Bye.